This is a presentation on ACL tear by Aaron Bailey and Tina Bova. The anterior cruciate ligament, or ACL, is one of the most important ligaments regarding knee stability. Its primary job is to restrain anterior translation of the tibia on the femur, and it also acts as a secondary restraint to rotational forces in a non-weight-bearing knee. The ACL is a commonly torn ligament in many athletes, with female players having a notably higher rate of injury. ACL injuries can be acquired through means of a contact force or a non-contact force. A contact ACL injury usually happens with excessive lateral force applied to the outside of the knee. This often occurs in the case of a traumatic event or accident, or in the case of a sport involving tackling like football. A non-contact ACL injury is usually acquired by planting and cutting, landing on a straight knee, stopping with the knee in a hyperextended position, or sudden knee deceleration. These types of injuries are the ones more commonly seen in the athletic while competing or playing sports. Generally, when the ACL is injured, one will usually hear a pop and the knee buckles with a feeling of instability. These are the classic hallmark signs that a severe ACL injury has occurred. In terms of the prevalence of the condition, about 200,000 ACL injuries occur each year, which goes to show how common the type of injury really is. Approximately 2/3 of these injuries are treated with surgical reconstruction of the ACL ligament involving a graft. As previously discussed, women are at more risk for a non-contact ACL injury due to their ligamentous laxity, smaller joint congruency, and decreased musculature. Men tend to have stronger connective tissues, larger joint spaces, and an overall increased muscle mass in general. In addition, women are 2 to 8 times more likely to sustain an ACL injury in the same sport for a variety of sports across the board. It is of note that soccer has the highest rate of ACL injuries than any other sport, with basketball coming in second. Finally, 70% of all ACL injuries are non-contact. ACL injuries can usually be diagnosed from the patient, subjective and history, including mechanism of injury, location of pain, and immediate swelling. Patients will generally report that their mechanism of injury was due to a twisting motion on a planted leg. They usually felt or hear an audible pop and encounter immediate loss of motion, instability, and pain. The pain can be located anteriorly, medially, or laterally. Additionally, the patient will report immediate swelling within the 2 hours of injury. ACL injuries are usually diagnosed with clinical testing and MRI imaging. Pertinent to physical therapy treatment would include performing the anterior jaw and Lachman special test to evaluate whether the patient displays increased anterior translation of their affected leg. In terms of medical care, the gold standard of treatment if an ACL injury is suspected is to perform an MRI for confirmation of the injury. Following MRI and discovering the extent of the tear, surgery is usually recommended for reconstruction of the ACL to regain full motion and function. On this slide, you can see an intact ACL in the image on the left. The ligament is distinctly running from the posterior aspect of the femur to the anterior aspect of the tibia. On the image on the right, the ACL has completely torn and frayed, and little to no ligament remains intact. Common signs and symptoms unique to an ACL tear are the following: knee popping or giving out, anterior tibial translation of the tibia on the femur, pain over the knee, immediate dysfunction and swelling, instability or knee buckling, and the inability to walk without assistance. Atrophy of the quadriceps and decreased range of motion is usually a clinical finding for an ACL as well. As discussed before, The pain pattern for the ACL is indistinct, with pain radiating all around the knee joint. Mainly, the pain will refer to the medial and lateral aspects of the knee. Common clinical findings for an ACL injury include certain positive special tests, including a positive Lockman's test, a positive anterior drawer test, and a positive pivot shift test. The therapist may also find tenderness to palpation over the joint line, effusion and hemarthrosis on the involved side, lack of full extension, and decreased range of motion. In females, you may find an increased Q angle. When performing manual tests, you may also find weakened or atrophied quadriceps. As mentioned before, reconstructive surgery is an option for ACL tears. The ACL connects the tibia and the femur. The ACL may be reconstructed by a graft taken from another part of your leg. During surgery, the torn ACL must be removed and replaced with a graft through holes drilled in the femur and the tibia. After the graft is passed through the holes, it is anchored in place with screws or other hardware devices. The incisions in your skin are closed with stitches, glue, or staples. Physical therapy interventions vary depending on whether the ACL was surgically reconstructed or not. If the ACL is surgically repaired, during weeks 1 through 4, the goals of physical therapy are to decrease effusion with modalities, work towards achieving full extension, weight bearing as tolerated, and quad and glute sets. During 4 through 10, PT goals now are working towards full pain-free range of motion, balance exercises, mobilizations, and working to increase strength. During weeks 11 through 24, the goals have now changed to increase power and strength and moving towards functional related exercises and increasing balance and proprioception. More than 6 months post, PT goals move to a return to sport status with running progression, squats, range of motion equal to the uninvolved side, and maintaining strength gains. Non-surgical physical therapy goals include an early phase with perturbation training in all directions, working towards full extension and strength training. During the middle phase, goals move towards sport-specific activities matching muscle responses to perturbations and strength training. In the late phase, interventions have moved towards increased difficulty of perturbations, obtaining accurate selective muscular response, obtaining full range of motion, agility, and strength training. Prognosis for rehab is dependent on the motivation of the patient. Athletes tend to have very good prognosis because they are driven by the motivation of sports participation. People with a sedentary lifestyle, however, who may be classified as copers, may not have as good of a prognosis due to their lack of motivation. Non-surgical patients who avoid high-risk activity usually tend to heal more successfully. Surgical patients usually return to sport and are at a higher risk for a second ACL tear. Many athletes report a full return to sport activities within 6 to 12 months post-injury. Outcome measures for ACL injuries include the IKDC, the LICE-Home, the Cincinnati, and the Knee Outcome Survey for ADLs. The IKDC, or International Knee Documentation Committee, takes into account patient symptoms, sports activities, function, and ADLs, and has an MCID of 3.19 to 16.7 points. The LICE-Home Knee Scoring Scale asks the patient about 8 items, including presence of a limp, use of support for walking, locking sensation in the knee, giving way sensation in the knee, pain, swelling, climbing stairs, and squatting. The MCID for this questionnaire is 10.1 points. The Cincinnati questionnaire also looks at 8 items including pain, swelling, giving way, overall activity level, walking, stairs, running activity, and jumping/twisting. The MCID for this questionnaire is 14 to 26 points. Lastly, the knee outcome survey looks at ADLs, including specific symptoms, functional limitation with ADLs, patient rating of usual ADLs, overall function of the knee during usual ADLs, current level of daily activity, and a 24-hour pain pattern. The MCID for this test is 7 points.